So I'll take maybe 10 minutes, which I hope will expand on the generic stuff I was saying earlier. And then if you would like me to show you any concrete examples of the applications on OpenClinical, I'm happy to do that. So what I'm trying to do is to get some convergence between what we would call the knowledge life cycle, which was that 4 blob thing that I presented earlier, if you can remember it, and the data side of it. So this is, again, just a reminder of the Institute of Medicine definition of what a learning healthcare system is. I probably don't need to dwell on that, given everything that's been said. But the emphasis is on it's driving the process of discovery and improving practice as a natural outgrowth of actually delivering care. This is Abernethy's view of it, read that, which is very much focused on cancer. I don't know whether cancer was the ASCO, the American Society of Clinical Oncologists, have kind of committed very strongly to a program to deliver learning health system in oncology. And so this is her take on yet another of these cycles. And the specific model has at the top of it, and I'll revisit this motif, what the clinical guidelines, such as NICE guidelines, but in this case it's the National Cancer Coordinating Network, that were written to inform practice, depending upon clinicians to read, absorb, apply the contents of the guidelines. And then the clinical sites in the old model simply report on their practices by recording and sharing the new model now record and share their clinical data in a database with a form that can be analysed. And so it's aimed at oncologists and patients, and they're focusing on a number of service quality indicators that they're kind of recording regarding the actual delivery of care, and the objective is to promote awareness of evidence and research among the clinicians, but also capture the data back into the centre. The OpenClinical model is another cycle, but is very much technology. So we have a suite of authoring tools. So we would take something like a NICE guideline or pathway or whatever it may be. We'd mark that up and create a machine executable version of it. So this is quite a skilled task, but nevertheless quite a quick thing to do. And then the concept is you take this electronic version, you upload it to a database where it goes something like a process of peer review. So we took your COPD content, transform it, combined with the existing content. It's not a replacement for the NICE content. It's value adding. Would be reviewed as a tool that could be used at the point of care. So a peer reviewer might come in, put their own patients through it or whatever, and at some point it would be accepted for publication. We see this as a sort of publishing model. It goes into the public repository, where it can then be used by any respiratory physician, either out of curiosity or for research purposes, for kind of running a clinical trial of how would this change my outcomes compared with usual care, for example, and then recording all that data into a central data warehouse, which can then go into the same sort of process that the ASCO model expects, and then feeding back into updating the guideline. Right? So it's actually the same old picture, but with a technical stroke publishing gloss. Yeah? You agree with that?
Yeah, absolutely.
And so going back to this sort of motif, we would say take clinical guidelines, quality standards, whatever the content is that inform practice. OpenClinical provides the platform for translating guidelines into decision support and pathway management at the point of care. But then as a side effect of using that, facilitates data capture, and it might be a good idea if I actually show you one for simplicity, and sharing of the content. So anybody can download these published pathways and adapt them for their own purposes or criticise them or whatever. And provide immediate guidance. They can immediately influence routine practice and learning, and the feedback to researchers and guideline providers comes out of that. In terms of the IOM's sort of vision, this is a quote from the Abernethy paper, the things highlighted of what they see as the payoffs. So the notion of clinical data is a public good. They provide tools for managing the data, mining the data, providing clinical decision support systems, adaptation to the pace of change, just their headlines, new clinical research paradigm, encouraging synchrony of effort by every respiratory physician, every oncologist, every working together to establish consensus and share experience, expertise. This is an American-based view, of course, but incentives are aligned with practice-based evidence. So they're going to be paid more, or their hospital will get more if they're delivering evidence-based practice. They emphasise the opportunities for public engagement, have other roles, leadership roles, and so on. And I just went through those and said, how does the knowledge sharing model relate to that? So in OpenClinical, medical knowledge as well as data is regarded as a public good, and indeed NICE already does that, but just your knowledge is in the textual form. But we provided tools for creating a knowledge base, which is machine readable, which allows us to deliver clinical decision support systems, but of a very much more sophisticated kind, I think. It supports change in practice, potentially supports translational medicine, because new treatments, new trials can be run within this framework. You can model a clinical trial. I can show you this, a clinical trial, in this formalism, and actually run the trial as an application. Supporting consensus building about best practice. The emphasis here is not on incentivization, but the open access, open source, access to the knowledge, and public engagement through use, data and knowledge being available to everybody, and so on. So it's just a slight device to try to kind of say this is really the same sort of concept, can be translated into the learning environment, but the emphasis is on the mirroring of the data and the knowledge. Any questions? And then I can just run a quick demonstration if anybody would like to see one.
Would you mind just mentioning the bullet point you just skipped over about the trustworthy? I think it was trustworthy.
What?
Sorry.
No. I hate Macs. I don't know why everybody thinks they're wonderful. It's probably. Was it this one?
Yeah, trusted knowledge. I almost read all three words. Knowledge broker, trusted knowledge broker. Because I suppose that's where I was going a bit with my questions. That yes, when we were using that example of booking your flight, there are all those sites, and we can have preferences. But as soon as one site kind of lets you down, you're never going to go there again. And how do you, or how does a platform become trusted as the broker of knowledge, and what guarantees are there that everything's in there or 80%'s in there? And I'm not quite sure I'm forming the question right.
Well, it's about governance.
Sorry?
It's the governance stuff.
Well, can we specifically look at that in a moment? Once I've got online, then I can answer. Hope I can pay proper attention to your question. And so I'm just looking for.
And I had another thought, which is a different subject, but the looping back of all the information back to the guideline developer. So I'm again specifically thinking about NICE, but then how do we at NICE handle that, and what do we do with that information, and potentially the volume of all that stuff, and when does it start to then change what we say? How? And that's a question I need to take back to NICE, but I don't think we're set up to handle that level of feedback at the moment.
I'm sorry, you'll have to bear with
No,
me. I'm just trying to do something very simple here, which is to get online. There we go. There's my phone.
I mean, there are a huge number of data quality and integrity issues in and around the loop in the way that you're describing there. And I mean, we were talking earlier about when NICE was established, etc. And there was a lot of effort to look at across different clinical domains at formalising standards for practice in different. I can't remember what the buzzwords were 15 years ago, but it was in that sort of area there, which led on then into sort of guidelines and things like this. Yeah. And they just discovered, when putting all the different eminent people from Royal Colleges together to talk about how in gastroenterology or respirology or whatever they were capturing what they taught as the basis of good practice, that each group, you know, the respirologists are interested in smoking behaviour, the cancer docs are interested in smoking behaviour, etc., as an example. And yet, if you went through and then you put one up against the other, the NHS was collecting smoking behaviour in 10, 15, 20 different ways. And that's deeply rooted, and partly for good reason, that aspects of these things that are captured out of the phenotype need to be more closely and granularly defined in some clinical disciplines than do the other. Even though they're going under the same label, they're nonetheless collected in different ways for good reasons, because that relates to decisions that have to be made and how things are monitored, etc. So underlying this, you have to be really careful in standardisation. You don't throw your babies out with the bathwater. But ideally you'd like to say, well, it's all patients smoking cigarettes, etc. Why can't we just harmonise all that all the way through? Well, you can't, and you need to be able to have that variability somehow modelled in the way that you capture it. Okay, so you have a methodology for capturing that content, but you can vary its granularity depending on the particular context. So that's all right at the heart of where Open Air is on this, with the archetypes and the way that, I mean, that whole story. But it does mean when you come to query data, and you've got to be really careful that you're not mixing apples and oranges. That something connected in one particular context is not necessarily going to mean what you think it's going to mean when you put a blanket query right across the whole lot of it. So there's a huge amount of tacit knowledge. I mean, John's a sort of expert in all this sort of domain that you need to take into account when you're seeking to harmonise and bring all these things together. And that is a massive issue of governance in and around you know what you do and don't standardise and how you do it. I mean, there's one key question in all of this whole domain. I mean, the strategy is relatively easy to get a group of people sitting around and say, right, yeah, that's what we're going to do. All of the devil is in the detail of how you implement things, and you know the implementation side of it and what it means in practice is, you know, I'm sort of known in Open Air for saying our three most important priorities are implementation.
Yeah, I think I've heard you quoted.
Yeah, well, that was me. And it's true that you know the strategy is relatively straightforward compared to the reality of life in all of these sorts of ways, both for fundamental reasons in and around the science and the clinical practice, but then for all manner of reasons about systems and organisations and so on and so forth. It's a really complex domain to standardise. Well, I mean, it needs to be done. I mean, absolutely needs to be done, but with eyes wide open, really. Trouble with these things, we tend to simplify them and too far. Sorry, John, I was just filling
no,
you
not at all. No, thank you. Thank you. Yes. yeah. So, if I can sort of try, if I've understood the question, it was slightly thrown by governance, and then I think we were also talking about standardisation of data and everybody using terms in a standard way. So I'm not quite sure. Correct me if I'm wrong.
I guess I had two questions. So, governance was one,
yes,
and the other one is what the feedback loop to whoever it might be. But I'm specifically thinking about NICE. What does NICE do with all of that stuff?
Right.
And at what point do we say, okay, that means we need to change what we've said?
Well, remembering implementation, it may well be that the OpenClinical implementation of this concept isn't the one that NICE would choose to do. So you might, for example, take this platform and adapt it specifically to meet NICE's requirements. But if you just take the generic model, the governance about quality at the moment is primarily about peer review in the first instance, but then closing back to the practitioners, the community and the patients, by actually seeing how you do and recording all of that data. Suppose NICE has its own data warehouse. For every one of NICE's guidelines, there was one of these applications that I'll show you. Then every time it was run by somebody, you would be capturing everything about the patient, everything about the decisions, and potentially everything to track the patients, what the outcomes would be. There are governance issues surrounding the usual security questions and all the sensitivities, the care.data thing, and so on and so forth. OpenClinical is a publishing model. We aren't primarily intending to address that. What we can do is to make that, or we hope OpenClinical will make the model, the publishing model available, the platform available, and then you manage your own governance in whatever way is appropriate. But let me try to make this a bit more concrete with looking at a specific example.
Just before you
yes.
go on, John, could I just come back to that second question about the feedback to NICE and how NICE handles it? Because it's interesting that NICE already has a learning cycle, because you get your group together, they come up with the recommendations, they come up with the guidelines, and then they publish them and they go into use, and then they come up for review, and the group gets back together, and the group has a hierarchy of evidence. So they'll rate systematic studies, Cochrane reviews and so on. They'll rate higher than RCTs, they'll rate RCTs higher than they'll rate observational studies, and they'll rate those higher than they'll rate expert opinion, for example. So where I would see that feedback to NICE going is that will come somewhere in that hierarchy. The real time, the evidence of the use coming from the use of those things will come back in, and the next time the group meet to review the guidelines, they take account of that. You'd have to decide how that was ranked within that hierarchy, but I mean it would feed in at that point, presumably.
I'm wondering about the volume as well, but we'd have to come up with solutions.
So Nina, why do you think volume is an issue?
Well, I guess it's my lack of imagination of how this feedback data, but I'm imagining if we're hearing about every outcome, that's millions of records, or potentially millions of records coming back, and there's going to have to be a way of.
But the whole world of big data, essentially, this isn't a problem anymore. This is just a technology. So scaling is just to solve the problem. You buy it, that capability. I mean, the level of the individual clinician, the volumes of data are small. They're probably modest by comparison with what perhaps happens on the net routinely in terms of an individual hospital, even a big one. And even NICE is probably, for the whole of the NHS, if we would kind of take this model forward, you're dealing with large amounts of data, but not astronomically large, any larger than the kinds of things which are already being supported by Google and countless other big data organisations, as I see it.
Yeah, each individual data set's not necessarily huge. Some are, but the number of different data sets in different contexts is probably pretty massive, isn't it? I mean, that's the point.
I may be being naive, but I think this is basically a solved problem.
Yeah, well, I used to chair PubMed, in the UK for Wellcome and British Library. I think one of the really good initiatives that people like NICE could put their weight behind is a goal that's there for PubMed. I'm not chairing it now, I haven't been for the last 2 or 3 years, but which is to try and move to a situation where, at the same time as you have open access publication, you get the data into the same kind of frame of publication, so that a lot of studies, you never see what the data are, and to be a good scientist, you really do need to have a handle on data and to be able to work with it. And I think it would take the whole field of research into practice forward a long way if we began to create, alongside massive repositories of the publications, that the data on which those publications were based should be there in a similarly accessible way. And I think that would go quite a long way towards creating an environment where some of this stuff could get greater traction.
So I think the ASCO saw that as, in terms of managing large quantities of data and learning from it, as the payoff for them. the Nesta quote I gave, I think they had a broader vision, which was about sharing knowledge, which OpenClinical is trying to address. But could I I think it might inform what we're talking about. If I just show you one example, this is this hereditary one I use because it's a rather nice, well-developed application by a doctor, not by a programmer. And this is the kind of one view of the nice pathway. This, if I just make that larger, this is using our tools, you create this sort of visual representation, but it's a visual representation which maps actually onto the clinical processes, admitting the patient, deciding whether there's a pathway that is appropriate for them, doing an initial workup. This might be a kind of triage nurse if you want to think of it that way. The workup might be done by a junior doctor who makes decisions about imaging, placing the orders. The radiology department produces the reports. A more experienced doctor makes the management decision. And these are all modelled in a form which I'll now show you how that can be run. Okay, so if I now we call it playing the demo, this application. I don't believe it. This has never happened before. Looks as though it's going to determine to hurt me. Are we online? We are. I'm not going to.
Can we keep asking you questions?
Yes, please. I'm sorry. This is.
Yeah. I was just going to ask. You mentioned about Ewan and Hot Handy, etc. Have you got a dialogue going with him about layering the pro forma sort of methodology onto the open air based platform that they're?
Yes. Let me segue to that elegantly by apologising that for some reason this is not working. I'm going to try and sort it out when there's a quiet moment. But what Ewan is trying to do is create this platform. If we quickly, hopefully we can go to his website, Handy Health, and there we go. And this is, as I said, this is a project which is about trying to create a platform that lots of organisations can use to share services. So there can be lots and lots of apps that are accessed by people through their mobile phones, whatever it may be, maybe patient services, doctor services. And then behind this kind of open access and open source technology layer, there's things like Open Eyes, Open Air, various versions of Open Air, OpenClinical. So people can use those to use this platform to access and try out and test these services. And NHS England, as I understand it, is supporting this first phase of trying to show that this is an operational way of delivering.
I was involved in the first round of this, right. But I'm not involved in it now.
So I feel we've kind of my fault. Sorry, we've lost a bit of clarity about what we're trying to do. So let me return to the kind of the starting point, which I was hoping to just bring into the conversation. The ASCO model, or the Institute of Medicine model, is very much focused on what benefits can we get by recording large amounts of patient data that would feed back into both improving practice by giving the clinicians feedback about how well they're doing against 81 whatever quality standards, but also as a side effect providing information back into research, onto new models of care or new treatments, and also back into the processes of creating public standards like guidelines. The OpenClinical model is very much compatible with that, but the emphasis is on is not just on data capture, recording information through electronically into a database, but actually giving advice, suggestions, prompts, reminders based on the content in what is currently just a written guideline.
Can I ask a question? Can you model systems with this?
Can you?
Model systems. One of the things I work in mental health, I'm a clinical director, and services are getting cut. And we have guidelines for individual disorders, depression, psychosis. But what we don't know is what are systems doing? What do inpatient wards do for people with mental health problems? What do acute psychosis services do? And we don't have guidelines for them. We don't know. We can begin to measure outcomes, but could this model systems about what happens to people when they go into psychiatric wards?
You mean in terms of workflows or in
clinical outcomes?
I wouldn't start here. This is not. If I've understood the question, OpenClinical isn't about there are software and other techniques for tracking patients. You know, what's happened to them as they present, and what's through their journey, seeing what happened to them. And that's very much a specialist field, and I think there are a number of companies that have provide products to do that sort of thing. It's not.
So it's more it's the system rather than the specific intervention.
What OpenClinical applications based on the content from OpenClinical can do is, as patients go through their journey through a defined pathway, for example, everything that happens, including the decisions taken, why they were taken, what the clinical situation was at the time the decision was taken, all of that can be recorded, as well as making suggestions and recommendations to nudge the clinicians to follow the NICE or other kind of practice. Does that make sense?
It does. I mean, because the difficulty for me is any given condition, you could manage it in different environments, and which environment should we be using? And there isn't evidence for that.
Yes.
We don't know, and it has massive economic implications about where people should. If you're psychotic, should you go into a ward, or when should you go into a ward?
Well, okay.
What does the ward do to you when you go there, and what factors influence it?
There's like research questions in a way, aren't they?
They are research questions, but can we map that clinically again from the earlier discussions, rather than double-blind RCTs? Can we model this within healthcare systems? Yeah. Can we use this to map it? What factors about the ward input matter? What factors from the person, their demographics or their illness matters? What affects outcomes?
So he's challenging you. How can you learn from what your formalism, John, I think?
So we can map the people going through. What do we learn about the systems that are impacting on them?
So this, in this picture, one of the things that doesn't bring out is that once something's been published, you can use it as is, but you can also, somebody can download the pathway and say, we want to run this in a different way. We want to manage this clinical process in a different way. So I'm not going to try and think of the situation that you have in mind, because I don't have the knowledge. But you can create a version of it. I mean, our concept was that, you know, a pathway for managing hypertension developed in Boston, in the States. Somebody might say, "Oh, we really like that. The science is good. The medical criteria for making decisions are good. But we actually manage our hypertensive patients rather different in Bognor than they do in Boston. We have less resources, less facilities. We just do things differently." And again, in Botswana, they have a completely different set of things. So you can download the content, adapt it for your local purposes, upload it, and run a different variant, still using the core knowledge in a way that is being proven and validated through peer review and a variety of other ways. Is that half an answer to your question?
It does. I don't think it answers the question that I've asked. I don't think it answers the question about what do we do. Right. So I could, if I'm thinking about depression, I could model it on a ward, and I could model it on a community team, and then I could do the same with psychosis or anxiety. Yes. But what I want to do is I want to model the ward, or I want to model the team rather than the condition. So to take hypertension.
Well, so we don't model, again, it may be just language that we're using, the terms different. We don't model the condition, we model a process, a workflow, if you like.
Okay, so I could model the inpatient workflow.
So you could model exactly, and then you could have 2 or 3 different workflows, and you could select the one that you actually wish to follow on a particular occasion.
Are you trying to model the Are you trying to use this to predict the
Yeah,
outcomes?
I'm
Yes.
very sorry about this.
No, we can try to
And to know what this is what the service is doing. I don't know if inpatient wards get people well. I think they do, but I can't. Do they do it any better than community services? They're far cheaper.
Input, so you're not sure
And there
how
are
they rank in
multiple
terms of significance.
types of problems going through at the
But you
moment.
do have a good sense of the outcomes.
We've a sense to get people well. I don't know if they're the best way to do it.
Yeah.
So I've got various
'Cause-
different types of inputs for different conditions. They,
I mean, they're pretty standard statistical kinds of techniques as well, aren't there, to take into the mix on various kinds of regression analysis, and then it tends to be used quite a lot. Obviously, more amorphous Bayesian network kinds of predictors, things of that kind, and you could formalise it with something like Proforma as well, and then put some statistics on top of that.
And we've come across ICHUMs, the International Consortium for Outcome Measures, and what they want to do is they're developing what they call standard sets, which are basically frameworks of outcome measures for each condition. So for anxiety, there'll be a standard set that looks at, at the top level, mortality, right through, symptoms, different symptoms that people have, the effect on function, and they'll use all the standardized scales. Effect on function, they'll look at the adverse effects of the treatments that we give them, they'll look at remission and recurrence, maybe at the bottom level. And then they say, don't even bother with the comparative effectiveness stuff. You can't do that from the data that they produce, but they use it to benchmark, and then they use that as a kind of management tool. So there's a trust over here that's producing really good results on this particular care pathway, and then you might use John's system to map the workflow, and then we've got another trust over here that isn't doing quite so well, and then they would say, well, why is that? And then they might go back and look at the different workflows and see what could be causing it. But they wouldn't even get into the detailed statistical analysis. They would just use the basic, outcome measures, which is a slightly different approach, I suppose.
This is actually a project that we did for the American Association of Clinical Endocrinologists, who write guidelines specifically in endocrinology. And we set out specifically to kind of add value to this. It's just a PDF here, but then on the right-hand side, we've got this decision support system. We build a standardized data model for the physical examiner, patients presenting with thyroid nodules, for information about test results. The data are linked into the original guideline. You can see it's highlighted. But we can also actually model the pathway. I'll just hide this. And what this is doing is now taking you through that process. And you can see this is flashing. This is recording information about the patient in a standardized way. It's then there are two decisions about whether to do a TSH or a calcitonin test. So the clinician confirms the recommendation, and we move on. We're moving down the guideline, the pathway, and it's recording the information about the patient, making suggestions for any case where there is a decision to be taken. We can, in principle, I think I forgot to tick an important block. Let me do this one. Yeah. So at any time, we can also look up the link to the original guideline, or potentially a local document. So if I click on this, what I've shown you quickly here is there's a recommendation not to do a calcitonin assay for this particular patient because there's a reason not to. There is a reason to do it, and we can just click on that and go back to the original guideline. It takes us straight to the specific point in the guideline. And the OpenClinical repository is full of a lot of examples of that kind of thing. So the summary then is that we can record all the data, we can do the analysis, we can give recommendations at the point of care, we can help manage the workflow, and maintain a database of contents for future, for quality assessment and clinical audit as well as for research. Thank you for giving me 2 more minutes. I'm sorry we had the problem.